Hey future nurses, welcome back to Scribbling Spoon. Your nurse here. How are you all doing? Thank you for your support always. Okay guys, today's NCLEX review is gonna be long, right? Why? Because we are talking about 5 NCLEX most tested pediatric disorders, and I know you need this. You need to learn this, okay? So you have to be patient throughout the review. You have to watch till the end. Subscribe, like, share, put in the comment section your best part of this review, okay? So the pediatric disorders we'll be talking about we are talking about RSV, we are talking about CROUP, we are talking about Kawasaki disease, we are talking about epiglottitis, and we are talking about Tetralogy of Fallot. Okay guys, now let's go. The first question: a child with Tetralogy of Fallot has frequent TET spells. Which physiological mechanism explains this condition? A. Increased pulmonary blood flow due to ASD. B. Right to left shunting due to pulmonary stenosis. C. Left to right shunting causing oxygenation. And D. Overproduction of hemoglobin leading to cyanosis. Guys, I'm gonna tell you the right answer, and I have to break this down to you guys so that you can understand what they're asking you. And the right answer is B. Right to left shunting due to pulmonary stenosis. Do you know what's going on here? Now you have to understand what is Tetralogy of Fallot to be able to answer this question, okay? Now, what is Tetralogy of Fallot? This is 4 congenital heart defects in one, right? And the congenital heart defect that is under Tetralogy of Fallot, we use PROVE to remember them. The P stand for pulmonary stenosis, and the R stand for right ventricular hypertrophy, and the O stand for overriding aorta, and the last one, which is V, is ventricular septal disease. So these are the 4 congenital heart defects that is combined when you talk about Tetralogy of Fallot, okay? Now the question they are asking you is that what is the mechanism, the physiological mechanism that explain TET spell? Now, what is TET spell? TET spell is cyanosis or bluish skin due to lack of oxygen supply to the baby, and this happen when they are awake, when they are crying, or they are feeding. That's when TET spell happen. So now the question they're asking is that what is the physiological mechanism? What causes this TET spell? Is B. Right to left shunting due to pulmonary stenosis. Now you have to understand what is pulmonary stenosis, because that is what causes lack of oxygen, which leads to cyanosis during TET spell. Do you understand it? So in simple terms, the physiological mechanism that causes TET spell is because the pulmonary stenosis blocks blood from going into the lungs, and this increases right to left shunting of blood, and this sends the oxygenated blood to the system, and that is when the baby have TET spell. Sudden drop of oxygen level in the blood, and the baby begins to turn bluish on the skin, right? And that signifies lack of oxygen, and this happens when the baby is either crying, feeding, and either awake. And so that's why some of the supportive care, when baby is awake, you try to provide a calm environment for them to avoid triggering TET spell. You give them pacifier to calm them down, okay? So that's why the right answer is B. So let's go through the wrong choices. So the first choice says increased pulmonary blood flow due to ASD. ASD is atrial septal defect. Now, remember I told you we use PROVE to remember the 4 heart defect under Tetralogy of Fallot. and then of Fallot. So we do not have atrial septal defects under TOF. What we have ventricular septal defect. Prove V, ventricular septal defect. So that makes A wrong. It says atrial septal defect, but we have ventricular septal defect in TOF. So that makes A wrong. And B is our right answer. And C, left to right shunting causing oxygenation. No. In TOF, we have right to left, not left to right. So we have right to left shunting, okay, resulting in less oxygen, sending the oxygenated blood to the system. So that makes C wrong. And D, overproduction of hemoglobin leading to cyanosis. First off, overproduction of hemoglobin will not lead to cyanosis. So that makes this option very wrong, okay? And like I have explained, that cyanosis is caused by mixing of deoxygenated blood, sending deoxygenated blood into the system, okay? And it is not caused directly by hemoglobin level. So that makes that option wrong. Now let's move on. A 2-year-old child is diagnosed with viral CROUP. Which nursing interventions are appropriate for managing this child's condition? Now, select all that apply. Before we go into the select all that apply, let me explain what is viral CROUP for you, so that it is easy for you when we're going through the select all that apply to pick the right choices. Now, what is CROUP? CROUP is a viral infection. It is caused by a virus called parainfluenza, which causes inflammation of the trachea, the bronchioles, and the larynx, causing narrowing of the airway or leading to narrowing of the airway. That is CROUP, and this can lead to some signs and symptoms you will see will be dyspnea, difficulty breathing, right? And the hallmark signs and symptoms of CROUP: barking cough. On your NCLEX school exam, once you see barking cough, know they are talking about CROUP. Another hallmark signs and symptoms is inspiratory stridor. And what is stridor? Stridor is high pitch sound you hear due to narrowing of the airway. That is what stridor means. High pitch sound due to narrowing of the airway. So that's another hallmark sign of CROUP. And another sign you will see is tachypnea. You can see fever. And what is the treatment option for CROUP? You can give them nebulized epinephrine, right? You can give them corticosteroids to reduce the inflammation, okay? You can also encourage the parent to have cool mist humidifier in the child room, because that would help to soothe the inflamed airway, okay? And also you will ensure the child is calm. You remember we're talking about pediatrics. The child is calm because agitation will worsen the symptoms. Now that you know that I've given you brief explanation of CROUP, let's go through the choices. How do we do? And this is select all that apply. And how do we treat select all that apply as true or false? Now, A, administer nebulized epinephrine as prescribed. Absolutely, I said that, right? B, encourage oral hydration. Absolutely. You know why? Oral hydration will help to thin the secretion, okay? And that will help to promote respiratory function, helps them to breathe properly. C, perform frequent deep suctioning. Absolutely not. Deep suctioning can actually worsen laryngeal edema. You know, I said CROUP is inflammation, viral infection that causes inflammation of the larynx, the bronchioles, and the trachea. So you don't want to suction the patient, okay? And D, provide cool mist humidification. Absolutely. Cool mist humidification can help soothing the inflamed airway. So this is right, okay? And the last one is place the child in prone position. No. Prone position will worsen the symptoms, will worsen the condition, especially for the airway. So you want to put them in upright position, because this position encourage proper breathing, help oxygenation also, okay? So Now our right answer is A, B, D. Administer nebulized epinephrine, encourage hydration, and D, cool mist humidification. Okay, now let's move on. A 5-year-old is brought to the ED with suspected epiglottitis. Now, which is the priority nursing action? A, prepare the child for throat culture. B, administer oral antipyretics. C, keep the child calm and avoid throat examination. And D, place the child in Trendelenburg position. Guys, the right answer here is C, keep the child calm and avoid throat examination. Avoid throat culture in epiglottitis. Hold on, let me explain it to you. Now, let me explain what epiglottitis is. Now, epiglottitis is a life-threatening bacterial inflammation of the epiglottis, okay, causing narrowing of the airway. And this happens to kids mostly between 2 and 5 years old. And kids that are at greater risk of getting epiglottitis are kids that are not vaccinated with the HIV vaccine. Let me explain to you why kids that are not vaccinated with their HIV vaccines are at greater risk of getting epiglottitis. Now, epiglottitis itself is caused by HIV, Haemophilus influenzae type B. That is HIV. So that is what causes epiglottitis. So if you get vaccine, HIV vaccine, you are vaccinated against HIV and you will be protected against getting epiglottitis. So this is why these kids that are greater risk of getting epiglottitis are kids that are not HIV vaccinated. Okay? And some of the signs and symptoms these kids will experience will be drooling, muffled voice, dysphagia, that is difficulty swallowing, sore throat. Okay? So that is some signs and symptoms for epiglottitis. Nursing consideration for epiglottitis. Never you obtain throat culture on any patient experiencing epiglottitis. Why? Because that may lead to loss of the airway. So your priority with patients experiencing epiglottitis is securing the airway. So never you obtain throat culture on them. Okay? So now that you know that, you see why our answer is C, keep child calm and avoid throat examination. Why? Because throat examination may lead to loss of airway, narrowing, obstruction of the airway, and we don't want that. Okay, guys, we do not want that. Sometimes it might look like I'm staying too long on one question, but I want you guys to get it, because nursing is not about cramming, it's about understanding. Once you understand it, no matter how they twist the question, you are able to answer it. So pardon me if I'm staying too long on each question, because I just want you guys to get it. Okay, all right, so let's go through the wrong choices. Now, prepare child for throat culture. I just said it. Never. Okay, now administer antipyretics. Yes, they may have fever, but we are looking for priority: airway, breathing, and circulation. The priority is securing the airway. You can administer oral antipyretics later, and antipyretics are medication that are used to treat fever. You can administer that later, but your priority right now is securing that airway, because when the airway is gone, the child is dead. Remember I said it affects children mostly between 2 to 5 years old. When the airway is blocked or lost, the child is gone. Okay? Now, and D, since C is our answer, and D, place the child in Trendelenburg position. Why do you want their leg in the air? To worsen the situation, right? that will cause difficulty breathing for them. That will worsen the situation. So you want to have them sit upright. That helps them to breathe. Or in tripod position, because that also help breathing. Okay, now let's go through the next question. Now, a nurse is caring for a child diagnosed with Kawasaki disease in the acute phase. Which interventions should the nurse anticipate? Now select all that apply again. A, administer IVIG. B, okay, select all that apply again. Now because we do select all that apply together as true or false, before we go into it, let me explain what Kawasaki disease is. Kawasaki disease is systemic inflammation of the blood vessel, that is autoimmune vasculitis, that affect children under 5 years old. Okay, and I need you to know that Kawasaki disease is divided into 3 phases. We have the acute phase, the subacute phase, and the convalescent phase. Now in acute phase, because this question is asking about with Kawasaki disease in acute phase, let me tell you, in acute phase is very interesting. Kawasaki disease is very interesting for it to have 3 phases. In acute phase, the child will experience fever, high-grade fever, 38 upward, and this fever will last for between 1 to 2 weeks. You can imagine burning for 1 to 2 weeks. High fever, hallmark, sign of acute phase with Kawasaki disease, right? And despite using antipyretics, that is medication to treat fever, this fever will not resolve or go away. Interesting, right? That is Kawasaki disease. And also another hallmark sign of Kawasaki disease that you will see, strawberry tongue. Strawberry tongue is swollen red tongue with bumps on them. You will see that in Kawasaki disease. Now you will see erythema or redness around the body, red or chapped lip. Okay, you can see pale skin, redness on the palm and the sole of the feet. These are signs and symptoms of Kawasaki disease in the acute phase. And we have the subacute phase. We have and in the subacute, and we have the convalescent. Like I said, in the subacute phase, finally the fever has decided to go. The clinical manifestation like fever is resolved, but there can still be some arthritis, pale skin, or pale hand, pale feet. Okay, and in the convalescent phase, all clinical manifestation has subsided. Okay, but there can be some elevation of some labs like CRP and ESR. When these labs are elevated, they are signifying there's the presence of inflammation. And treatment, straight up treatment for Kawasaki disease is IVIG, intravenous immunoglobulin, and high dose aspirin. Get this, I know, remember they will tell you not to use aspirin in children with viral infection. Note, viral infection. Kawasaki disease is an autoimmune vasculitis. So this is not bacteria, it's not viral. So the acceptable treatment for Kawasaki disease is IVIG and high dose aspirin for children. And the reason why they will tell you not to use aspirin in children with viral infection is because of Reye syndrome, but we're not dealing with viral infection here, we're dealing with Kawasaki, so aspirin is accepted. So after educating you now let's go through the choices. Okay, now administer IVIG. Absolutely, select all that apply. We are doing that now. Absolutely, give aspirin as prescribed. I said that. Absolutely. Now monitor for coronary aneurysm. Absolutely, because cardiac monitoring is essential in Kawasaki disease. Monitor for myocarditis, arrhythmias. Okay, so C is true. Now D, restrict all activity for 3 months. That is 3 months is long. In acute phase, you can reduce activity because the child actually have fever. The child will not have strength to play. So you can reduce activity while the symptoms persist, but 3 months is too long, right? It's too excessive. Now apply an E, apply cool compress to rash. Cool compress are not treatment for rash, right? Actually, in Kawasaki disease, if the patient, the child should have rash, the rashes will not be pruritic or itchy. So, and cool compress is not treatment for rash. So that makes it wrong. So our answer is A, B, C, okay? Now let's go. A nurse is assigned to care for a hospitalized infant with RSV. What isolation precautions are required? A, contact and droplets. B, airborne only. C, standard only. And D, reverse isolation. Guys, before I tell you what the answer is, right, run away. I've been saying it. If you watch my videos, I say run away from any option or choices that have only, all, always. Cancel them out. Always run, cancel them out. So the right answer is contact and droplets. Now, RSV is is transmitted through respiratory droplets, and the isolation precaution will be contact and droplets. Okay, so the right answer is A, contact and droplets. Now let's go through the wrong choices. B, airborne only is wrong, and airborne is not for RSV. You can use you can put patients with measles, patients with TB will be on airborne. Standard only, no. Standard precautions is used for all patients regardless of their diagnosis or condition or infection. Standard, but that's not what we use for, because it says only. We are not using, that's wrong. And reverse isolation, no. Do you guys know what's reverse isolation? Reverse isolation is actually used for patients that are immunocompromised, like patients that are on chemo because they have weakened immune system. So now this isolation is actually protecting the patient from getting infection, not the patient spreading it out. So when someone is on reverse isolation, the goal is actually to prevent or to protect the patient from getting infection. Okay, so that is reverse isolation, but it's not applicable to RSV. Now let's go. Which statement by a parent indicates understanding of the medication for moderate croup? I've explained what croup is. It's caused by parainfluenza that causes inflammation of the larynx, bronchioles, and trachea, narrowing the airway. So now my child will need antibiotics for 7 days. That's A. B, the steroids will reduce swelling in his airways. C, he must be kept nothing by mouth until the infection resolves. And D, we should keep him lying flat to rest. Now the right answer is B, the steroids will reduce swelling in his airway. We know that steroids helps to reduce inflammation, and I said it is the inflammation of larynx, bronchioles, trachea. So the steroids will help to reduce inflammation. Now that's our right answer. Let's go through the wrong choices. My child will need antibiotics for 7 days. Guys, these test writers will trick you, so you have to look carefully. Sometimes it is just one word that will change the meaning of the whole answer. Now look, antibiotics. Remember, croup is a viral infection caused by parainfluenza. So why would you give antibiotics for a viral infection instead of antiviral? So that makes that answer wrong. So for croup, we use antiviral, not antibiotics. Okay, now let's go through the next one. It must be kept nothing by mouth, NPO, until the infection resolves. For how long? So you're telling me that if the infection takes up to 2 weeks, the child for no reason will be placed or will be kept on nothing by mouth. No, that's not right. So that makes that answer wrong. Now D, we should keep him lying flat to rest. Actually, lying flat will worsen the symptoms, especially when the airway is involved. Sitting up or tripod position helps them to breathe properly. Okay, so that is wrong. So that makes our right answer. The steroids will reduce swelling in his airway. Now let's go. A nurse suspects epiglottitis in a child with sore throat and fever. Which sign is most concerning? A, drooling and tripod positioning. B, nasal congestion and cough. C, mild inspiratory wheezing. And D, productive cough with sputum. And so guys, the right answer is A, drooling and tripod positioning. Now I know you will tell me why, or you ask me why. Because you will say drooling and tripod positioning are expected in epiglottitis, because some of the signs and symptoms you will see when patients have epiglottitis, like I've explained what epiglottitis is, inflammation of the epiglottis, which is a life-threatening bacterial inflammation of epiglottitis causing narrowing of the airway. In signs and symptoms, you see drooling, you see tripod positioning. Yes, the correct answer, which is drooling and tripod positioning, are expected signs and symptoms in epiglottitis. But why is it concerning? Because it is indicating that the epiglottitis is getting worse, is getting severe. The airway obstruction is getting severe. Because think about it, when a patient assumes tripod positioning, they are assuming that position to help them breathe better or properly. So they are in kind of respiratory distress. So when you're still drooling and tripod positioning, it may suggest that the epiglottitis is getting worse. Now, let's go through the wrong choices so you will see why we are still sticking to A as our right answer. Nasal congestion and cough. You will see this in normal flu or even RSV. With RSV, they could have nasal flaring, coughing, sneezing. Okay? Now, C, mild inspiratory wheezing. Asthma. You will see that in patients with asthma, wheezing. Okay? Now, or even COPD patients. Now, let's go. Productive cough with sputum. You will see that in actually COPD patients when they have productive cough of or sputum with with yellow, green, or rust color sputum. You will see this productive cough with pneumonia patient, COPD patient. Okay, so that makes D wrong, and we are still sticking, even though drooling and tripod positioning are common signs and symptoms of epiglottitis. But when you see it, you know that they are in severe obstruction of the airway. The airway might be narrowing up or obstructed. Now let's go. Now, during a text spell, what is the nurse's priority action? A, administer oral bronchodilators. B, place the child in knee to chest position. C, give rapid IV fluids. And D, obtain blood pressure and ECG. Now guys, the right answer is B, place the child in knee to chest position. Why? Knee to chest position helps to return blood to the lungs, and this helps to return oxygenation to the child, right? And reduce the severity of the sinuses, which is the bluish of the skin, because of drop in oxygen level due to right to left shunting and increase deoxygenated blood in the system. Okay, so knee to chest position When you put the baby in knee to chest position during test spell, like I said, this is bluish of this skin, which is indicating lack of oxygen. During when the baby is crying, feeding, or just awake, they can have test spell episode. You put them in knee to chest position. This helps to return oxygen to the body. This helps to return blood to the lungs and reduce the severity of cyanosis. Okay, so that's our right answer. Now let's go to the wrong choices. A, administer oral bronchodilator. This is not asthma. Why are we giving them bronchodilators? So that is wrong. Now C, give rapid IV fluids. True, IV fluids may be used later on, but repositioning is the priority, because repositioning is the immediate intervention to return oxygen quickly to the body. Okay, so IV fluids, like I said, may be given, but it's not the priority over knee to chest positioning. Now, the last one says obtain blood pressure and ECG. These are secondary. Now, assessments are secondary to immediate intervention. What can you do quickly to save the baby? Because once they have test spell episode, you know what is happening. So putting them to chest position, knee to chest position, help quick oxygenation back to the body. Okay, and that's why our answer is right. Our answer is B, place the child in knee to chest position. Now let's go. Which findings should the nurse expect in a child with Kawasaki disease? A, strawberry tongue, peeling hands, conjunctivitis. B, vascular rash, dry cough, irritability. C, periorbital edema, fruity urine, hypotension. And D, photophobia, bulging fontanelle, and nochial rigidity. And guys, the right answer, I have said this before, so strawberry tongue should have given it away. The right answer is A, strawberry tongue, peeling hands, and conjunctivitis. Okay, these are all mass signs and symptoms with Kawasaki diseases. You will see that. Now let's go through the wrong choices. B, vascular rash, dry cough, or irritability. You can see this in illness like chickenpox, varicella, okay, and not Kawasaki disease. Now, C, periorbital edema, fruity urine, and hypotension. This suggests nephrotic syndrome and not for Kawasaki disease, okay? And the last one, photophobia, bulging fontanelle, and nochial rigidity. Nochial rigidity alone should let you know that that's meningitis. Okay, so it's not for Kawasaki disease. So the hallmark signs and symptoms of Kawasaki disease: strawberry tongue, you see peeling hands, you see conjunctivitis, right? You see redness around the body, red chapped lip, okay, lymph nodes, enlarged lymph nodes, hallmark signs of Kawasaki disease: peeling hands, redness on the palm and sole of the feet. Okay, now that's good. Let's go to next one. Which infant is at highest risk for severe RSV infection? Now, A 1-year-old with seasonal allergies. B, a 2-month-old born at 34 weeks gestation. C, a 3-year-old with mild eczema. And D, a 4-month-old exclusively breastfeeding. Now first, before I tell you the right answer, let me explain to you what is RSV, Respiratory Syncytial Virus, right? So it is a viral infection of the lungs and bronchioles in infants, especially infants that are less than 6 months old. In fact, RSV is the most common cause of infant hospitalization, okay? And this really happens around the winter period, the fall period, the cold season, the flu season, because the signs and symptoms you will see in RSV, sorry guys, will be nasal flaring, coughing, sneezing, you know, because RSV is actually transmitted through respiratory droplet. I think I've explained it before. And the isolation precaution for RSV is droplet and contact, right? So now with my little explanation, right, you should be able to guess the answer. The right answer is B. Look at the age. A 2-month-old born at 34 weeks gestation. Immaturity, the baby being born at 34 weeks can actually also put the baby at risk of getting RSV. Okay, that's our answer. Now let's go through the wrong choices. A 1-year-old with seasonal allergies. Allergies are not a condition or risk for RSV, so that is wrong. Now a 3-year-old with mild eczema. Eczema doesn't increase the risk of RSV, so that's wrong. A 4-month-old exclusively breastfeeding. Actually, that's the best. Breastfeeding or breast milk is the best nutrition for babies. So, and that actually also help contain the nutrients to help them fight infections. So that is good. The only child with greatest risk is a 2-month-old born at 34 weeks. Okay, that makes our answer B, right? Okay, let's go. Which signs and symptoms are commonly associated with croup? I told you guys before. A, barking cough. B, drooling. C, inspiratory stridor. D, high fever with toxic appearance. E, hoarseness. And F, tripod positioning. So let's go through it. As it's letter that apply, we'll go through it as true or false. Barking cough, absolutely. The classic sign of croup, barking cough, yes. Drooling, no. Where are we going to see drooling? Epiglottitis. Now, inspiratory stridor, absolutely, due to narrowing of the airway. So that's possibility in croup. Remember I said inflammation of the bronchioles, of the trachea, larynx, bronchioles. Okay, and what is inspiratory stridor? I mentioned it. It is the high pitched sound you hear when the airway is narrowing. Okay, now D, high fever with toxic appearance. Actually, croup generally exhibits low-grade fever and not toxic. High-grade fever, where are we going to see that? Kawasaki disease. Kawasaki disease. So that makes that wrong. E, hoarseness. Absolutely. Hoarseness can be seen due to the inflammation of the laryngeal. And remember, laryngeal is known as the voice box. So hoarseness is when the voice is not clear when you're talking, like your voice is muffled. So that's seen because of that inflammation of the laryngeal that can occur. Okay, and F, tripod positioning. You will see tripod position, drooling, tripod positioning, like I told you, epiglottitis. So makes our answer A, C, and E. Okay, guys. Now let's go. A 5-year-old with Kawasaki disease is receiving IVIG. The nurse knows the child should avoid which of the following for the next 11 months. Remember, like I told you, that IVIG, intravenous immunoglobulin, is what is given for patients that have Kawasaki disease. That and aspirin, high-dose aspirin, is the treatment for Kawasaki disease. Now, this child that has received or that is receiving IVIG, what kind of now the question says the nurse knows the child should avoid which of the following for the 11 months. Now, A, influenza vaccine. B, MMR and varicella vaccines. C, pneumococcal conjugate vaccine. And D, Tdap vaccine. Let me tell you the right answer. The right answer is B, MMR and varicella vaccines. A child that has received IVIG should not take live vaccine. And example of live vaccines are these measles, mumps, and rubella. This is MMR and varicella vaccine. They shouldn't take live vaccine. And you know why? Because IVIG may affect the way their body reacts to the vaccine, and it may make the vaccine less effective. So that's why they'll say for 11 months after administering IVIG, no live vaccine. Okay, so that makes our answer B. Now let's go through. For A, influenza vaccine, C, pneumococcal conjugate vaccine, and D, DTaP vaccine, they are inactive or subunit vaccine, and they can be given. The only one that shouldn't be given is B. Now let's go. Which of the following are clinical features of RSV bronchiolitis in infants? A, wheezing. B, nasal flaring. C, dry barking cough. D, use of accessory muscles. E, profuse drooling. And F, fever. Let's go through it as now you know what RSV. I've been explaining it. A, wheezing, yes. You know why? Because the signs and symptoms they will experience when the baby have RSV are signs and symptoms like sneezing, nasal congestion, nasal flaring. And if that persists, that can cause narrowing of the airway. Why? Because of congestion in the nose. The airway, you know, there is upper and lower airway. The nose can also be congested and breathing might be difficult. And when breathing is difficult, you will hear wheezing. Okay? Now, B, nasal flaring, just like I've explained, yes. Runny nose, coughing, sneezing, yes. Now, dry barking cough, no. You will see this in CROUP, barking cough. D, use of accessory muscle, yes. Because when they're in respiratory distress, finding it hard to breathe because maybe they have a lot of nasal congestion, nasal flarings, even as an adult. When you have cold and flu and your nose is congested, sometimes it's very hard for you to breathe, and sometimes you breathe through your mouth because there's congestion and the nose, the nostrils are blocked, congested in there. So yes, so they may use accessory muscle to breathe. Absolutely. Now, profuse drooling, no. You see this in epiglottitis. And F, fever, yes, they may experience fever. So our answer is A, B, D, F. Okay, now let's go. Which diagnostic finding is most expected in a child with Tetralogy of Fallot? Now, A, atrial septal defect. B, left ventricular hypertrophy. C, boot-shaped heart on chest x-ray. And D, pulmonary edema. Now we are looking at diagnostic finding, and the right answer is C, boot-shaped heart on chest x-ray. Now this is a classic finding in TOF due to right ventricular hypertrophy, and that's why you will see the boot-shaped heart on chest x-ray. Okay, now let's go to the wrong choices. Atrial septal defect. Actually, like I said, we use proof, right, to remember the 4 congenital heart defects in TOF, Tetralogy of Fallot. Now, this one is saying atrial septal defect. No, we see ventricular septal defect, not atrial. And the next one says, B says left ventricular hypertrophy. No, we see right ventricular, which is the R, right ventricular hypertrophy. Okay? And the last one says D, pulmonary edema. Pulmonary edema is not a common feature in TOF, so that makes that wrong. Now, let's go. Which nursing interventions are appropriate for a child hospitalized with Kawasaki disease? Select all that apply. A, monitor for signs of heart failure. B, apply cold compress to rash. C, administer aspirin as prescribed. D, encourage frequent ablation during acute phase. E, monitor temperature closely. And D, F, provide soothing oral care. So let's treat it as all, select all that apply as true or false. Monitor for signs of heart failure, yes. Okay, you have to monitor for signs of arrhythmias or myocarditis with Kawasaki disease, so which may lead to heart failure. So yes, monitor for signs of heart failure. Apply cold compress to rash. I have said it before, no, cold compress is not a treatment for rash, so no. Okay, now say administer aspirin as prescribed. Absolutely, that's one of the treatments for Kawasaki disease, aspirin. And D, encourage frequent ablation during acute phase. The child have high-grade fever in acute phase, and they are experiencing all the signs and symptoms: strawberry tongues, pale skin, redness on the palm, on the sole of the feet. You have to reduce activities, right? You have to limit activities during this phase. So do not encourage frequent ambulation. The word is frequent. You have to limit activities during this phase. Monitor temperature closely. Absolutely. Like I said, they have high grade fever, so monitor temperature closely. Yes. And provide soothing oral care. Yes. Mucolitis and cracked lips require oral care, so that is right. So our answer is A, C, E, F. Okay, guys, you are almost at the end of this review. Thanks for staying tuned. I know it's long, but I just want you guys to get it. Okay, now let's go through the few ones. Okay, now second to the last question. A child with RSV bronchiolitis has worsening respiratory distress. Which assessment findings requires immediate action? A, audible wheezing. B, oxygen saturation of 92. C, apnea and cyanosis. And D, mild intercostal retraction. Guys, we are looking for which assessment require immediate, your priority action, which the right answer is C, apnea and cyanosis. Apnea is sudden cessation of breathing or of breath during sleep, combined with cyanosis, lack of oxygen or sudden drop of oxygen level in the blood. This is the greatest red flag from what is on the list, because this is signaling respiratory failure. Okay? And immediate intervention is required. Now let's go through the wrong choices. Audible wheezing. When they have RSV, like I said, I've explained it to you, because of congestion in the nose, wheezing is possible. From this list, it's not your greatest priority. Oxygen saturation of 92. This is concerning, right? Because the oxygen level should be between 95 and 100. But it is just slightly from 95 compared to apnea with cyanosis, right? And mild intercostal retraction is showing respiratory distress. It is showing mild intercostal retraction is showing that they are in respiratory distress. But you see, this apnea with cyanosis can signify respiratory failure. So respiratory distress and respiratory failure, which is of the greatest red flag? Respiratory failure. This combination is dead ass. So, and the last one, guys, the last one, I'm glad we made it. Now, which of the following is true regarding epiglottitis? It is a viral infection managed with supportive care. It can be prevented with HIV vaccine. It causes gradual onset of symptoms over several days. It is treated with nebulized racemic epinephrine. Guys, and the right answer here is B. I have explained this. The true statement is it can be prevented with HIV vaccine, because actually in the first place, HIV is what caused epiglottitis. So that's why I said kids that are not vaccinated with their HIV vaccine are at greatest risk of getting epiglottitis. So the right answer is if you get your HIV vaccine, you are prevented against epiglottitis. Let's go through the wrong choices. It is a viral infection managed with supportive care. Guys, don't get it twisted. I told you epiglottitis is a bacterial infection, so you need antibiotic. So it's not a viral infection. Don't let them trick you. Now, it's caused gradual onset of symptoms over several days. No, the onset is abrupt and severe. Drooling, tripod positioning, muffled voice, sore throat. It's severe and sudden. Now the last one, it is treated with nebulized racemic epinephrine. No, what is treated with nebulized racemic epinephrine is CROUP and not epiglottitis. Okay guys, we made it. We have completed our review today. Thank you for staying till the end. Don't forget to like, subscribe. Bye.